But whatever the story, the qualities that made the adhesive such a failure were the very qualities that made it such a success. It was an adhesive that didn't stick, at least not for very long. That might not have made it useful for the original intended use, but it made it spectacularly useful for an intended use. As for Viagra, the brand name of Sildenafil, it was a drug that was intended to treat hypertension, high blood pressure, and angina, chest pains. It did work for that, but it had a curious side effect. Men taking it reported prolonged erections. But what is one man's side effect is another man's happy evening. Patented in 1996 for treatment of hypertension, by 1998, the FDA approved sildenafil for erectile dysfunction, and soon after 2 other similar drugs for treating erectile dysfunction came along, Cialis and Levitra. How can they help treat cancer, you ask? And are they safe for women? Yes, they are safe for women, and I'll get to that in a moment. But here's how they work on your immune system and give you a boost in fighting cancer. Viagra, Cialis, and Levitra are all members of a class of PDE5 drugs. That means that one of their own side effects is that they reduce MDSCs, myeloid-derived suppressor cells, which is exactly what you want if you want your immune system to take on those tumors. MDSCs are similar to the T regulatory cells we discussed in Chapter 2. Remember how they worked as screening agents to determine if something was a friend or foe, and were easily tricked by the clever cancer that pretended to be a friend and belonged in the body? Well, like T regulatory cells, MDSCs also interfere with anti-tumor immunity, and they do so by using L-arginine metabolisms to suppress immunity. Arginine is an amino acid critical to a healthy immune system because it is required to activate T cells. But when cancer is present, tumors and regulatory immune cells produce an enzyme called arginase 1, which breaks down arginine in the tumor microenvironment. But one thing that controls this process is the phosphodiesterase 5 inhibitors, otherwise known as PDE5. PDE5 inhibitors reduce the myeloid-derived suppressor cells, MDSCs, and suppress arginase production, which means that tumors have one less ally in their quest to grow and reproduce. The role MDSCs play in the immune response is a hot topic right now in cancer research, though currently there are no available treatments specifically for controlling them. At present, the best source of PDE5 and arginase 1 inhibitors currently available are the popular drugs for erectile dysfunction, Viagra, Cialis, and Levitra. And yes, women can take them safely. They haven't proven to increase arousal as some women and drug marketers had hoped, but just as they stimulate blood flow to the penis, they can stimulate blood flow to women's genitals, which can increase sensitivity to stimulation. And that's not such a bad side effect when the payoff is increasing stimulation of the immune response for a woman battling cancer. These drugs, as in any other treatments discussed in this book, need to be taken under the supervision of your physician. Drugs such as Viagra, Cialis, and Levitra can cause significant decreases in blood pressure. Patients with low blood pressure may not be able to use them. Dipyridamole. Dipyridamole is a drug used to treat coronary and peripheral artery disease. It reduces clots and dilates blood vessels. A study published by Rhodes et al. In Lancet, March 23, 1985, demonstrated that melanoma patients given 300 milligrams of dipyridamole a day had a 5-year survival of 77% versus an expected survival of 32% in patients not treated with dipyridamole. One initial thought was that since this drug reduces platelet aggregation, it might decrease the ability of cancer cells to spread in the blood and adhere to other locations, creating metastasis. In a study published by Spano et al. In Clinical and Experimental Metastasis, January 2013, titled Dipyridamole Prevents Triple-Negative Breast Cancer Progression. They demonstrated in the mouse model that dipyridamole decreased the primary tumor by 67.5% and metastasis formation by 47.5%. In their study, they discovered that dipyridamole produced a significant decrease in tumor-associated macrophages, TAMs, and myeloid-derived suppressor cells, MDSCs, both which boost the anti-cancer immune response. Dipyridamole also results in a decrease in adenosine, which is a metabolic suppressor of the immune system. As this study shows, basically, there are several mechanisms in which dipyridamole may help enhance the immune response. Zoledronic acid. Zoledronic acid is often used to prevent fractures from certain bone metastases, especially in breast cancer. Studies have indicated that zoledronic acid may reduce the future development of bone metastasis in breast cancer. On December 10, 2010, Kostia et al. Published a study titled Zoledronic Acid Repolarizes Tumor-Associated Macrophages and Inhibits Mammary Carcinogenesis by Targeting the Mevalonate Pathway in the Journal of Cellular and Molecular Medicine. This and studies have shown that zoledronic acid can decrease VEGF and reduce tumor-protecting TAMs, both which may enhance an immune response. Simvastatin. Simvastatin is an HMG-CoA reductase inhibitor, statin, which inhibits cholesterol synthesis. Several studies, including one by Liu et al., published in Psych Rep December 14, 2015, have shown that simvastatin can reduce IL-6 production, which is a cytokine that can result in immune suppression. There have been other studies that show this effect may be further enhanced when combined with curcumin. Rapamycin. Rapamycin is an inhibitor of mTOR, which blocks glucose metabolism and cell proliferation. This drug is dose-dependent and can result in increased Treg cells, which we do not want. In addition, it can lower proliferation in immune cells just as well as cancer does. Therefore, although it shows promise as an anti-cancer agent, its use must be closely monitored by a physician. Metformin. Metformin is a very popular diabetic medication that causes the increased uptake of glucose in muscle and reduces glucose production. It also inhibits mTOR, which results in decreased cell proliferation. It enhances T-cell killing of cancer, causing tumor shrinkage. Mepazine by Pridon. Mepazine is a phenothiazine antipsychotic medication. Bipridin is a medication used to treat Parkinson's disease and is a synthetic acetylcholine antagonist. Both of these drugs inhibit MALT1, which is associated with the CBM signalosome complex. Pilato et al. Published in an article in Nature Research October 2018 titled, Targeting the CBM complex causes Treg cells to prime tumors for immune checkpoint therapy. They demonstrated that using Mepazine to inhibit MALT1 could help convert immunologically cold tumors to hot ones. In the animal model, they showed the combination of Mepazine with PD-1 inhibitors causes the development of an anti-cancer immune response with relapse-free tumor control in a model that does not respond to PD-1 therapy alone. This is important as the majority of cancers do not respond to PD-1 therapy due to a lack of infiltration of attacking immune cells and a predominance of tumor-protecting regulatory immune cells. They also showed that MALT1 inhibition could actually convert regulatory cells into ones that are more tumor-attacking. The big advantage here is that most strategies are to decrease regulatory cells, generally by killing them. This drug may be able to make good use of those regulatory cells in the tumor environment to convert them into attacking the tumor. Mifepristone, RU486. Mifepristone, also known as RU486, is an anti-progesterone drug mainly known as the French abortion pill. Because of the controversy and various abortion laws in different countries, this drug, though promising, would be difficult to obtain even by prescription of your doctor. It is known that pregnancy creates an immune-suppressing condition so that the mother's immune system will not attack the fetus. This is related to progesterone and progesterone-induced blocking factor, PIBF. It is known that PIBF may have numerous actions that cause immune suppression against cancer, one being decreasing natural killer cell function. It is also known that some cancers produce PIBF as a defense against the anti-cancer immune response. Several case reports have discussed patients who failed traditional chemo and immunotherapies who have seen significant improved survival with mifepristone. This was described in cases of lung and kidney cancers and even cases of glioblastomas, GBM, a highly malignant type of brain cancer. Technically, it would be possible to measure PIBF production, which could help determine if this may be an immune suppressor in specific cancer cases. Right now, the studies are lacking, but you can certainly infer that mifepristone could be synergistic with other cancer immunotherapies. Hopefully, we will see more studies soon. Thymosin Alpha 1. Thymosin Alpha 1, T-alpha 1, is a peptide that enhances immune function in animals without a thymus and seems to enhance immune function in humans as well. T-alpha 1 used in animal studies reversed some aspects of immune suppression related to chemotherapy. It increases T cell function and the production of immune stimulatory cytokines such as IL-2 and IFNG and NK cell activity. In addition, T-alpha 1 upregulates toll-like receptor 9. Another important mechanism is that T-alpha 1 increases expression of MHC1, which can counteract a common mechanism that cancer can use to hide from the immune system. T-alpha 1 is typically used in the treatment of chronic hepatitis. The described mechanisms above certainly give us a reasonable idea that T-alpha 1 may be useful for enhancing the immune response against cancer, though studies remain limited. T-alpha 1 is typically given as a subcutaneous injection like insulin, usually twice a week. Mebendazole, fenbendazole, levemizole. I was considering adding a small paragraph on levemizole since it is a medication that we had previously used in our patients. However, at the time of writing this book, there was a lot of information circulating about a gentleman named Joe Tippins who seemed to have unprecedented success treating his cancer with a dog-warming medicine named fenbendazole along with a vitamin and supplement regimen. Certainly, these types of situations occur when isolated patients see unique results in their particular case. One of my colleagues in Mexico told me about levemizole 4 years ago and that it was not uncommon to use parasitic warm medicine in cancer patients there. He reported in 10 years, he had one patient that had a complete response using levemizole in an advanced colorectal cancer. Once in 10 years may not seem much, but for the patient, it was a life changer. In regards to levemizole, the data was limited, but I did find a 2007 publication by Shen et al. Titled "Levemizole Enhances Immune Response by Affecting the Activation and Maturation of Human Monocyte-Derived Dendritic Cells." There are also some human studies in the early 2000s that showed some synergy with chemotherapy, though nothing extraordinary. We used it for about 2 years, but the effect was unclear. Also, though levemizole may have some immune-stimulating aspects, it can cause immune suppression as well. Pulse or intermittent dosing may help avoid some of the immune suppression, but we just did not have good data, nor did we want to risk counteracting other immunotherapy treatments. In regards to fenbendazole, I did not find much data as well, likely because for an inexpensive drug such as this, it may be difficult to get funding for studies. One interesting article published by Zhao et al. J.M. Asic Lab Anasai, titled Unexpected Anti-Tumorigenic Effect of Fenbendazole When Combined with Supplementary Vitamins, describes that neither vitamins nor fenbendazole alone had any effect on tumor growth. In addition, they showed that fenbendazole alone actually increased tumor growth, which is concerning. However, the combination of fenbendazole plus vitamins given at a higher than normal level resulted in decreased tumor growth. I have very limited experience with fenbendazole in patients, but I have seen a few that did seem to have increased growth rate. It sometimes happens where a particular drug may work for some and may worsen others. Certainly, dosing may be a problem with these agents, as it seems there is a narrow window for the drug being helpful versus harmful. Hopefully, the increased interest created by Mr. Tippins will lead to further studies and better understanding of these drugs so that more people can be helped. I applaud people like Jane McClelland and Mr. Tippins for helping get information out about off-label drugs that may be helpful for cancer patients. Jane's book, How to Starve Cancer, and her Facebook page on off-label medications are definitely worth following. Now let's turn to baking soda and acid blockers and see how that can add one more powerful component to the anti-cancer cocktail. That is the focus of Chapter 11.